I'm Mandy Barter and I'm the co-founder of a charity called My Cancer, My Choices, and we give complementary therapy to people who are undergoing cancer treatment right at the very start of diagnosis. And so today is a podcast about men's health and especially in cancer. So I want to introduce Mark Foulkes, who is the oncology lead nurse at the Berkshire Cancer Centre.
Yes, thanks very much, Mandy. My full title, it's massive, is Macmillan Lead Cancer Nurse and Nurse Consultant. So I do a bit of a mixed role, really.
Okay.
Yes.
So what is your mixed role?
Mixed role. So there's two elements to my job. As the Macmillan Lead Cancer Nurse means that I have the Royal Berks in Reading. I take the strategic lead for cancer nursing. So looking at things like the way patients are looked after, I suppose in sort of general terms, I'm responsible for the standard of care for all cancer patients who are admitted to the Royal Berks. So that would be people who are end up on the breast cancer ward, having treatment, to people who have a very extensive treatment in the cancer centre. Of course, that's impossible to do. So, I don't know all these people. There's no way I could see them all. So what in real terms, what that is working with other senior nurses and doctors to make sure that the care's of good standard. So there's that element to my job where I advise and work strategically with the trust, and also I deal with any sort of, like, if there's complaints to do with cancer patients or issues, then I deal with that and try to troubleshoot that. The other part of my job is a more clinical job, which is the nurse consultant bit, where I'm a senior nurse who sees patients when they're admitted with emergencies relating to cancer. So I spend sort of a couple of days a week going around on ward rounds seeing patients when they're brought in as an emergency, and those can be patients who have a cancer that we know about and that we're treating, or it can be patients who have a completely new diagnosis of cancer, who have a problem brought in and then turn out to have cancer, say because they come in with blood loss or anemia or fall over at home. So there's the other groups of patients I see are patients who are known to have cancer but are looked after somewhere else. So they might be looked after, say, at the Royal Marsden or Oxford or in the private sector somewhere, and they come in as an emergency to us. So that's a nice mix in my work between the clinical and the managerial strategic work. So that's suits me down to the ground. I'm quite happy to do that.
Sounds busy.
Yeah,
it's really busy.
The other thing I should say, because it would be wrong not to, and UConns would be really crossing me if I didn't, is that I'm currently a board member and president-elect for the UK Oncology Nursing Society, which is the body that represents cancer nurses across the UK. So I'm a board member for them, and I lead for cancer nurse education for them. So. Yeah.
How long have you been a nurse?
How long have I been a nurse? I've been a nurse since January the 3rd, 1988.
And how long have you been in oncology?
I've been in oncology, let's think, would be about since 1993. So it's like 26, 27 years? Yeah, something like that. So, long time in showbiz.
Yeah, that is a long time. And we were talking about that earlier, and obviously you love what you do. I know you love what you do. And why do you love what you do?
Why do I love what I do? I think it's a privilege to look after people. I think it's a privilege to look after people with cancer. I think they're often people at their best when their back's against the wall, and I feel that it's a really important job, because sometimes people feel very isolated in those situations, even though people say things, "Oh, aren't you brave?" But people just get on with it. People that are not necessarily brave, they're just in a position where they cannot do anything else. You can't stop. You're in a position where you're forced to do your best. And I think in those sorts of situations, it's really helpful to people to stand by you. And I think it's really important that nurses do that. And I think that, even if sometimes the circumstances seem desperate when people are very ill and there's no cure for them, or then there's always something you can do to help. And I really believe that. And I think people find that difficult to say, "Oh, isn't it a terribly sad thing to be involved in?" But I don't think it's sad at all. I think it's often very privileged, often very happy places. People regard if you've been on a chemotherapy unit, they're not sad places. They're not sad places.
No,
they're places where people are engaged in the business of getting on with it.
Yeah.
I think and it's really great to be involved with that. And I get to know my patients. Really well. People come back for cancer treatments for many, many years often. Increasingly, people have long periods of treatment. They have, for somebody with breast cancer, for example, might have 7, 8 different sorts of treatment as time goes on over many years. So, and it's really good to be involved in that sort of work.
And the reason you're here today, because we had a chat one day about men in cancer and men's health. Yes. And we had and it was great because we changed our leaflets because you said that the perception around complementary therapies, what we do, is that it's just for women.
Yes.
And you said that sometimes nurses are just handing out the leaflets just to women.
Yeah.
So as a result, Mark, we changed our marketing and we've now got men's faces on some of the pull-up banners.
And it's kind of worked, I think, hasn't it?
It has. I tell you, this time last year, so in September last year, we had 12% referrals.
Yeah.
In September this year, we've had 44%.
That's amazing. So that's good. That's really good work. I mean, that's if you to get that sort of level of engagement with men is very difficult. And other places where I worked close to complementary therapy teams, they've not had anything like that. So that's really, really great. So congratulations to you.
Well, no, thank you. And also, I suppose, encouraging men. And what we found in the charity is that once you've got a man through the door, they actually stay for the course of treatment. So we give up to 6 treatments.
Yes.
And they will stay.
Yeah, and it's breaking down that barrier, isn't it?
Yeah.
I think it's men are very resistant to seeking help, and there's lots of reasons for that, I suspect.
Can we go through?
Yeah, I think I can tell you what evidence there is and why I think that is. Sure. So we know that men approach seeking help in very different ways. So what you'll find with men is that they tend to report things only when they have to report them, unless somebody makes it very easy for them to report things. So that's one issue. So often, if you look at sex-adjusted cancer, if you take things like breast cancer, prostate cancer, cervical cancer, uterine cancer out of the mix and look at cancers that affect both men and women, you can see that men do much worse than women. Their survival's worse, the way they cope with treatment is worse, and there's lots of reasons for that, but the main reason is they tend to don't report symptoms as readily as women, and when they do report symptoms, often that's later. So that already men are disadvantaged themselves by not reporting symptoms that they might have had for some time, and the reason for that is they think it'll get better. They regard themselves as like, if you admit that there's something going wrong with your body, it's a sign of weakness, which it obviously isn't. There's something gone wrong, but they don't. Men, I'll say they, I am one of course, is that it's much harder for men to report that without seeming weak. So I think that's a real issue. The other thing is that research shows that men, when they don't access help from areas like cancer information centres, they're very unlikely to walk in to a cancer information centre and say, I've got cancer, I've got these problems, can you help me? Less likely to do that. They might access through websites. They might access even through telephone more readily than walking in, because that's very difficult for them to do. What you'll find is my experience, and I think that at the Macmillan Cancer Information Centre at work, is that the partners of men will come in and ask, or families will ask, rather than the men themselves.
Yeah, really interesting.
So that's fairly typical. And I think that in order to appeal to men, they have to understand that they're not going to be alone. They're not going to be the only man. That's the other thing. So I think that's important what you've done.
Yeah.
I think it's important things like Look Good, Feel Better sessions, which are sessions around sort of traditionally targeted at women about makeup and things like that. But now we have ones that are targeted towards men, and I went to one of those sessions and they're great. And it's like, it's not abnormal. You can talk about, it's nice to be able to talk about shaving and things like that, and male grooming and things in a very sort of basic way. But at the same time you're having that, people are talking about their cancer.
Exactly.
So it feels effortless. And I think that's what men like. They really like it to feel effortless. They don't have to talk about their feelings unless they really, really have to. But I think that's not unusual for men. They don't necessarily But once they trust people and once they can see that it's something that will work for them, then they'll stick with it.
That's what we found. Absolutely.
And there's a certain loyalty as well, that men are very loyal. So if you give them one thing that really works, they'll stick with you. And that's what sort of research shows, I think. But it's interesting the way, I mean, men, for example, you look at melanoma, is that men are very unlikely to report a melanoma, and what you often find is that where places men get melanomas often on the back of the head or something like that.
Skin cancer.
Skin cancer. So often you rely on partners to report those things, and even if they did notice that it was there, which they might not, they might report it. That's it's just a mole. It's just it's just a thing. It will go away, and often it won't get better, will it? Unless people do something about it.
What do you think does work in engaging men?
I think anything group activity will work. Men work in teams. Yeah. We like working in teams. We've been brought up to work in teams. So things like, I think we're going to talk about PSA screening, aren't they? The lines that offer. I think part of the reason why that works so well is that it's a big group of men. Yeah. They're going to turn up, they're going to queue, which we love. Of course, we love queuing, because then we can chat and talk about how long the queue is. We can talk about various sports teams, but we can also, while we're doing that, it doesn't feel as if we're accessing healthcare. It feels like we're doing something different. Yeah. It feels like we're approaching it as a team. We're all in it together, and men love all that. And I think you have to be able to appeal to our group sensibility. I think you have to make it seem as if as well that you're helping someone else. That's a really big thing with men, I think. We all feel it says, I'll come to this group, but I'll help because others will be there, and I'll be able to help them in some way. Yeah. Not that I want to go because it will make me feel better, but because I want to help others. And that's my experience of looking after men for so long, is that there's always this pain is bad, but not as bad as this other chap's over there, so you should definitely go and see him first. But okay, I will do that, but what about your pain?
So that's how you appeal to men, getting groups together,
make things easy, make things that they can use. Technology, internet stuff is great. I think there's been a few successes, is that in things like young men in testicular cancer, we know that they won't go anywhere. They won't go to a place to talk about. But if you make it like if you have a chat room or something like that, they're much more likely to engage in that. And once they're in that chat room, then you can say, we could have a group based off that. Then they'll come to that. They won't walk into a room and have to introduce themselves and talk about testicular cancer straight off the bat.
Because is there a website called It's in the Bag? Yeah. And so, again, fantastic name for a website, and that's going to appeal to
and it does. And things
men.
like things like they've had lots of let's have a look at a few successful campaigns. Things related to football matches. We're talking about testicular cancer awareness and prostate cancer awareness linked to bowel cancer awareness linked to football. That's always good. They've got Movember is a really big thing, because that really appeals to men. Sort of the ability to, that sort of health promotion by the back door, talking about prostate cancer. So I think you have to have something that appeals to men's view of the world, really, which is significantly different than women's view of the world. And I think any sort of group activity, anything which would involve technology, will generally. I mean, the idea that you would sort of like go to like a garage of some sort and have your body checked out and things like that, with a number of short diagnostic tests, and it'll tell you whether you've got cancer and what to do about it, and we'll crack on with treatment right away, sort of appeals to a man. As long as you don't have to talk about how you might feel with that. I mean, that can come later, but men are quite practical like that.
Do you see that men don't perhaps take up counselling services less, or talking therapies less?
I think you have to. I think it has to appeal in the right way. I think you're right, they won't. But I think men will accept psychological support. One, if they're very distressed and they can't see a way out of it. And I think that men don't like to necessarily talk to their partners about these things. So if you provide a way of doing things and say to them, well, you don't really want to talk to your family about this, maybe if you could start by talking to us, then that helps. Men find it difficult to access because of the whole feeling feeling as if you're showing weakness, feeling as if you're being soft in some way, which is a real shame,
Yeah, it's a lot of pressure, isn't it?
It is a lot of pressure, and I think that it's quite complicated. The idea. It's diffused somewhat recently, but certainly when I was growing up, the idea that you men would be involved with childcare to any sort of degree there weren't men who were involved with childcare.
Yeah.
Now we're much more likely to see men pushing buggies around. I think it's a great thing, but I think that's been a gradual change.
Well, also maybe and your role as a male nurse.
That's a good point. I don't really think about that, but I suppose you're right. I mean. One of the greatest cards, one of the best thank you cards I ever had was somebody who I used to work regularly on our chemotherapy unit, and I got a card through that says on the ward, which says, "To all the angels on the chemotherapy unit and the bald-headed bloke," because I obviously couldn't be an angel because I'm not an angelic sort of person, but I was quite happy to have this indistinct role, and I think that's quite telling that people don't unsure what I'm doing some of the time.
Yeah.
I mean, they realise that the existence of nurses who are men, but is this one? I don't know.
Are you quite happy being called an angel?
No, I've never been called an angel ever. Lots of my colleagues have, obviously, female colleagues, but maybe I'm just not that angelic.
Well,
Well, I think that idea of being something a little bit different is kind of quite helpful.
Really helpful, yeah, because it sort of breaks down those stereotypes, doesn't it?
And I think often it's easier for me to approach men. I think it's hard to know because I can't really see it from the other way. But I think it's nice for men to meet another man, perhaps.
Definitely.
In that circle,
yeah.
those
No, I can see
circumstances.
that would be really helpful.
Yeah.
Really helpful.
Yeah.
So we had John from the Lions this morning talking on the podcast and talking about the PSA test and just as you said, getting a group, in fact quite a large group of men. I think the last time that they ran this was over 2,000 people.
Yes, it's a big old thing.
Yes, it's a big old thing, and you were saying about sometimes the results can be a bit complex with PSA tests. But what's your thoughts?
Well, my thoughts around PSA testing are I can certainly understand the appeal of it.
Yeah.
And I really don't. I wouldn't criticise the Lions for providing it. I think there were problems with the test itself. I think it can throw up a lot of. There are lots of things that can make your PSA go up, other than cancer, basically.
Yes. Yeah.
So that's one issue. So if you have an infection, or you've had some trauma, or you've got other issues, health issues, they can send your PSA up.
Yeah.
So what you tend to get with PSA testing, some of the positive results of high PSA testings are not cancer.
Yeah.
So that what we call in health are like a false positive. So you get, the PSA is raised, is it cancer? So that's one issue. So you could argue that people will be worried for no reason. The second thing is that many PSAs, you can have a raised PSA and you can even have a prostate cancer that's very early before it even causes symptoms, but then you're left with a problem that what do you do with that cancer? I mean, you could argue very clearly that once the person's aware there's cancer there, they'll be looking out for other symptoms. But then you've got a problem of you've got to investigate lots of people who haven't got cancer, and even people with very early cancers where you don't really have a way of treating that, and you might want to over-treat them. Given if you operate on people like that, you might cause all sorts of symptoms. So there's a balancing act for health. And that's probably the reason why there isn't a formal NHS sort of screening around PSA testing, because it does it even though it's a bit oversensitive as a test. Okay. So that's a reason why there isn't. Although I can really understand why people and there is an appeal for men getting together and doing these big pushes and turning up and doing their PSA. My urology surgeon colleagues would say, well, we've now got all these people who come through the door, most of which won't have cancer, or a significant number of them won't have cancer, that we now have to investigate. What I would say is that I make an appeal to people that men also have a view that as they get older and they say they're getting up in the night 3 or 4 times to pee, that's just a sign of getting older. It isn't. We do need to get that checked out. If you've got any symptoms like difficulty stopping and starting peeing, you should definitely get that sorted out. Any symptoms and certainly any blood in the urine, you should definitely go and see your GP. So sort of any urinary frequency feelings that you have to go much more frequently than you were before, peeing, then you should go to your GP. I would make that appeal. It's not a sign of just getting older. It's a sign that you might have prostate cancer. And there are other things that cause those things. There are the prostate, if you left it long enough, would get bigger by itself. And you get benign enlargement of the prostate. And those can cause those symptoms, but you need to get it checked out because there's a difference in where you treat those things. And prostate cancer is a very treatable illness. You can have good treatments for prostate cancer, and many people do very well with it. It's not a death sentence.
No. In fact, I think cancer research says it's 84% of men will live 10 years. There's a
it's a very treatable illness, and there is also research that if they did a big post-mortem study which said that if you look at sort of check people's prostate who are over 80 years old when they die, you'll find a significant proportion of them have prostate cancer. So it tends to be a cancer that you get as you get older, and you might have it and you might not know about it, and it won't cause you any symptoms and you die from something else. So there is that. Doesn't mean that you get complacent about it. If you get that prostate cancer at an earlier age, you should definitely do something about it. And there is things you can do.
Is there an age where you start to think around this now with men?
Well, I think that once you get above 50, you should definitely consider it. I'm at an age group that I'm now in myself, but I think that what we do know is that if you get prostate cancer at an earlier age, it can be more aggressive. So I wouldn't discount people from the age of 50 who get symptoms reporting to the GP, even younger than that. And I haven't looked after people with prostate cancer in their 30s and 40s, so it can happen. It's quite unusual, but it can happen. And I say it's all about the symptoms, really.
It's the symptoms.
Yes, the symptoms. You definitely need to report them. As with so many other things, I mean, the other big killer of men in the world of cancer is colorectal cancer, and men are often slow to report sort of rectal bleeding, trouble with their bowels. They're not used to talking about these issues and feel embarrassed about doing that, and they really should go to. So anything to do with changing bowel habits, certainly bleeding from your back passage, you definitely need to go and see your doctor.
So changes in bowel habit, bleeding, anything else?
Cramping, pain, weight loss, all of these symptoms are can be signs of bowel cancer. But just like quite subtle changes, constipation that you've not had before, diarrhea that you've not had before, also needs reporting.
Any kind of period of time with those?
I think that if you have a change in bowel habit that goes on for more than a few weeks, you should definitely go to your GP. Certainly, even one episode of rectal bleeding, don't discount it, go and see your doctor. Because people thought it might be piles. Well, it might be, but it might be something else as well. And even if it was piles, you might need them looking at. So I would say never discount bleeding from any part of the body, really. No. I think it's a bad sign. You should definitely deal with that.
A very obvious sign.
It won't go away by itself, often.
And what do you think, Mark? Because obviously we've introduced the complementary therapy service over the last 4 years. We have had more intake now with men. Do you think would you support the idea of men going?
Of course, I would absolutely support it. I think that there's lots of evidence. The evidence is quite rich to say that anybody, not men, or anybody who has cancer, who has complementary therapies, it will automatically increase the quality of their life. It will make them. It's something. Somebody from West Berkshire asked me for some data about what the main concerns were about people in West Berkshire, and about 4th or 5th in was like access to complementary therapies. So, but it's something our patients want and something that we definitely need to provide. It's not something that's based on illness, is it? It's based upon wellness. And I think it's, if we really believe that people should have a holistic approach to the way we look after people with cancer, and I do believe that we need to provide a whole range of things, complementary therapies being one of them, psychological care being another. I think you could also argue things like accessing relaxation therapy and things like that, or there's a whole range of things we can provide. Certainly there's a massive amount of evidence now that engaging in physical activity can have lots of positive effects, and that's another thing. So I think we've gone beyond just giving people drugs. I think, well, obviously drugs and radiotherapy are important, aren't they? Obviously they are. They're the mainstay of what we do, but there's lots of things we can do outside of that.
And it actually empowers people, because they can do it for themselves, and it takes back that control.
And you can teach people, can't you? You can teach people to do things which they, self-care is really important.
Really important.
Make people feel independent. So yes, I absolutely believe complementary therapies is something we should be offering alongside more traditional therapies. The other thing is that we're now in a position, because cancer care has been successful over the last 20 years, we're now in a position, we passed it a couple of years ago, 18 months ago, where 50% of people will survive more than 5 years with cancer. That's really good. I mean, that's an excellent. So we were treating, so more than half people will live through their cancer. But that means that you've got a whole set of people who have lived with a cancer diagnosis, who might still have cancer but are living with it, that we need to do something with. And I think we need to support those people, and having complementary therapies and other sorts of things they can do for themselves is really valuable. These people don't want to be and don't need to be coming to hospital, do they? They need to be looking after themselves, but knowing what the signs are of when their cancer might become more active, if it does. So they need to be able to come back to us. So a lot of our efforts are based around that, and I think that complementary therapies and other sorts of non-traditional therapies are exactly the right thing to do.
It's a way forward.
Yes, indeed.
Lovely. Mark, thank you ever so much.
No, it's a real pleasure. Thank you for inviting me.
Thank you.